Howdy, y'all. It's Dr. Jarvis again, and I want to do a short discussion here about some of the issues that are involved with psychiatric patients, patients with substance abuse disorders, who we need to get to either a mental health facility or an emergency department, and they're not very interested in going. So we got a panel of subject matter experts together, and we're going to discuss this. And we are basically going through a lot of the questions that y'all sent in to us. We may have restructured them a little so this flows a little better, but we really want to address some of the questions that have been out there. What I'd like to do is start off with a case study. And this is intentionally vague, and I don't really expect any specific answers about what y'all would do in this particular situation because I don't think that's realistic. But hopefully it'll give us a launching pad to discuss some relative or relevant issues. So let's say that EMS is called for a potentially suicidal patient. We arrive on scene to find a 42-year-old male who's an Army veteran, and he says he's been under a lot of financial stress. He got into an argument with his wife this morning about money, and during that discussion, he made the comment that he may as well kill himself because his family will be a whole lot better off without him. His wife was very concerned about that and made the call to 911. We show up. In our discussion with a patient, as soon as we get there, he says he didn't mean it. He's never tried to hurt himself. He doesn't really want to hurt himself now. He was just blowing off steam. But you also determine that he does have, you see some guns lying around the house. They call y'all for assistance. When you get there, and let's just say that he's not violent, he's cooperative, what are the things that go through your head, your algorithm, if you will, to determine what his real risk of being a threat to himself or others is?
So a few of the things that we're looking at is, first of all, the complainant. We would treat the complainant as a credible witness. We would interview her, get her side of the story. We would look at the victim, if you will, or the consumer. We call them consumers. We would look at his past history of hospitalizations, current diagnosis. We would look at the intent of his comment, the plan, if there exists a plan, access to following through with that plan. For example, if he made the threat to kill himself with a firearm, does he have access to firearms and how accessible are they? We look at the environment, his bedroom. Is he disheveled? Is he taking care of his daily needs? What does his car look like? There's so many different factors that we have to take into consideration to make that determination. Sometimes it can be really quick, and sometimes it can take an hour or two to gather all that information and make a good determination or a decision on what we're going to do with this person.
Okay. Something like that, from my experience, has been I'm looking at what they're not saying, by doing all these things, because 90% of the patients that we usually come in contact with, they're not openly admitting that they are suicidal to us when we get there. We were really having to base it off of what credible witnesses are saying, what the environment is telling us, what the things that they're not saying is what we're looking for, So again, a lot of the things, like as far as past history, they've made that comment numerous times in the past and haven't followed through, But even in this case, like that scenario, patrol would arrive on scene before EMS or even us, because there's not any medical concerns other than just the statement that was made. And patrol may say, they may have made that determination, so EMS or us may not even have been called. So,
okay. Are there, as an ER doc, I think in terms of red flags, so dealing with low acuity complaints, if there's any particular red flag that really grabs my attention, are there any red flags for you about suicidality? Risk factors. Yeah. So like does the fact that he's a veteran or a man have any effect on your decision making?
Again, red flags for us would be past history, intent, plan, PTSD. Are they a combat veteran? Okay. How he has treated himself, his wife, family members. Has he alienated himself? Everything we look at is a red flag for us that we have to investigate and either verify it or disprove it. Okay. So in our assessments, because we're doing a safety assessment, not a clinical assessment, we look at all those things as red flags and proceed with our investigation.
So, and bringing this back to clinical terms, we talk a lot about clinical gestalt. We have all these diagnostic rules for determining if someone has a blood clot. Now we have all these criteria, and none of them outperform. We do tons of research on this. None of them outperform what we call clinical gestalt, which is based on your experience as a clinician, and obviously the more experience you get, the better it gets. What I'm hearing you say is that there isn't really a specific written out, printed criteria. It's more your gestalt as an experienced officer.
Correct. We bring in what I call the human factor, just human conversation, common sense. I cannot base an assessment on a written form. I converse with the person and I follow their leads. And by following their leads, following their discussion is how I discover things and investigate them and uncover what needs to be uncovered to make a determination.
Okay. Well, let me change the scenario a little bit and say that he's been drinking a lot, drinking alcohol. Does that have an effect on either your decisions and determination about what his safety is, or what you do with him if you determine that he does need help?
Yes, sir. If we find out if the person has 1 or 2 beers, we can do a good assessment, talk to the person, get a good feeling for their thought process. I would say about 3 or more beers, maybe 4, depending on the person. The closer that they get to 0.08 blood alcohol level, then we start noticing, based on research, that the thought process starts changing. And so then the altered mental status at that point, we cannot determine if it's the alcohol or if it's mental illness. And therefore, that's one of the determining factors on whether that person needs to go to an ER and get medically evaluated or sobered up, and then present in a true fashion. And if they still are presenting the same, then we have a clearer indication that this is mental health. If they don't, or if they don't clear up, it's a true indication of mental health. If they do clear up, then obviously it was the intoxication.
Yep. Well, this is obviously something I'm very familiar with because I get, in the emergency department, we end up babysitting these people
Yes,
until they metabolize to freedom, if you will. But I think that's an important discussion is you have options other than calling EMS and saying go to the hospital
Yes, sir.
with patients. So I know we sort of lose perhaps perspective on that because the only time we ever have interactions with you other than at Starbucks is when you say the patient needs to go to the hospital. So you have some other options. How often do you take the patient directly to a mental health facility as opposed to getting us involved and going to the emergency department?
We average about 5,000 calls a year, and hospitalization is always our last resort. We always follow the law prescribes least restrictive, and that's our philosophy and mission as well. I would say 1 out of 5 contacts that we have end up in the ER. And that's from CIT's contacts and stats that we keep.
Okay.
And it's a ballpark figure.
So about, I'm an Aggie and my math is bad, but I think that means about 80% of all of your calls do not involve us.
Correct. That's about right.
All right, fair enough. And so let's say that they have been drinking. You make I use the term clinical determination. That's probably not the right term, but you determine that they're under the influence. That's not based on a blood. You don't have to do a blood alcohol level to determine that. That's based on your experience and saying that their behavior and actions are consistent with intoxication.
We're looking, if I may, we're looking at slurred speech, unsteady gait, redness in the eyes. We may do a nystagmus. On occasion, we'll ask the officer to do a nystagmus test, and if it's hitting on certain issues, then yes, that may make a determination.
Probably do that before we give them the ketamine,
Probably.
which is notorious for causing nystagmus. Although I kind of doubt after we've given them ketamine, you're probably going to, okay, go on your own.
Right.
So just to kind of go over some things, when we do this, we have a patient who's intoxicated, and you say, no, they really need to go to the emergency department. We take them to the emergency department. I've had some questions that say, well, what should EMS expect to happen there? And if you have a patient who is suicidal, they haven't done anything, but they've expressed intent, and they're also intoxicated, no mental health facility is going to take them. They're going to sit at least in my experience. They end up in my emergency department until they've metabolized to a point where they can be reassessed. And as much as that just gets under my skin because they're taking up a bed that a patient with chest pain could take up, I don't know that there's really a better answer. And I think frequently the emergency department and emergency services end up being the, well, there's no better answer people.
Yes,
So it doesn't make sense. We're really busy, but mental health facilities are really, really busy.
Yes.
They're way underfunded. They just don't have the ability to take care of people who are just drunk and aren't
Right.
suicidal. Do you have any idea of the patients that are expressing suicidality that are also intoxicated? We take them to the emergency department. They metabolize. They're sober when you reassess them. What's your experience on how many of those people are no longer suicidal?
That's hard to say because we don't get a call on all of them.
Fair enough.
Not all of them come across law enforcement. Sometimes they're taken by family. So we hear third-party information in conversation. Oh, by the
Right.
way, we had a couple of people last night that were drunk. We didn't call you.
Mhm.
We didn't. So it's really hard to get a good grasp. I know that in reading all the reports, we're having a higher incidence of alcohol-related, drug-related, prescription-related um, mental health issues
Mhm.
or comorbidity issues that just seems to be on the rise. And I'm assuming with the population growth, we're seeing more of it.
Yeah.
But it's hard to say, what the numbers are looking like.
I'll tell you, my experience is probably somewhere in the order of about 40%. So a pretty good number. Once they sober up, they wake up the next morning and go, I'm not suicidal. And you get a history from law enforcement that says, no, they do this fairly often. So it's not unheard of. And I can't believe I'm saying this on the record, that I think it's probably a reasonable decision requirement for these facilities to say that. Well, let's say you do determine
Yeah.
that they need to go to the hospital for whatever reason.
Yes, sir.
Can you possibly talk to us about what some of the relevant laws are that sort of are involved here?
Sure. Well, a lot of the process we've been talking about so far is under the Health and Safety Code, specifically Chapter 573. And this is with regard to law enforcement responding, possibly doing an emergency detention. All of that is contained in that chapter. In terms of transporting, I guess, before an emergency detention happens, you would look to your general EMS statutes in terms of how EMS handles the situation. You would also look at, we've talked before about the penal code and, the penal code chapter or section 9.34. And then I don't know if this is premature to get into, but I know there's been discussions about liability issues and concerns about that. And I know for EMS, I think our legislature and our courts have recognized the unique nature of EMS responders and other first responders in terms of assessing a crisis situation and having to make very quick decisions. And in that regard, there are various areas in the law that provide limitations on liability, and the general consensus in those types of limitations is the actor acting in good faith? Are they acting under within their scope of employment? Are they acting in their belief as they can under the law? And I know in these situations, EMS would be transporting by request of law enforcement. Law enforcement has taken that person in, if you will, custody, and is asking EMS to assist in a transport. So there are a variety of laws that come into play for this sort of thing, and those just generally.
Okay. Well, let me ask you a couple questions. I think you brought up some really good questions. Let's start with liability. So I think it is probably useful to make a distinction between criminal law and civil law, and just say that we're not talking about criminal law here, with one exception, and I'm going to get to that one, that I don't think is an issue, but I want to make sure that we say it's not an issue. Let's talk about civil liability. What is the chance that they could be accused or sued for whatever statute they pick to sue under?
Yeah.
And I'll stick with sued as opposed to anything after that.
Okay. Well, of course, I think all of us in our work as government employees and just the nature of our specific jobs, anyone can accuse a person of anything. Anyone can sue someone for anything. So to say that you can't be sued is, of course, inaccurate. The real question is, how successful can they be? And that is a very, that's a big question. Anyone who's talked to lawyers knows that we don't like yeses or nos, we like maybes.
Note to self, make her say yes or no.
But everything, of course, is very fact specific. But as I mentioned earlier, there would be a lot of things we would look at if anyone in our EMS department was faced with a lawsuit, including the various statutes that have limitations on liability and their applicability. We are a governmental body, so the next issue would be what immunities apply, and of course asserting those sorts of things as well. So that would be the process and the tool bag, if you would, toolbox of things we would look at for dealing with such a lawsuit.
So if we are sued, and we'll say under civil law here, and it ends up in a courtroom, and you're defending me as in my role as a paramedic, and so you make several defenses, one of which is in the statute, or several I understand. There are specific statutes that say you have immunity and thou shalt not win this case.
Right.
And then there are also arguments that you make. What are some of those arguments?
Well, I think some of the most obvious would be good faith arguments, public interest arguments. You know, we want our EMS. I would believe our courts would support the notion that we want our EMS departments to be able to respond and to make quick decisions without fear of, oh, am I going to get sued for this? And then to second guess themselves and possibly make a decision that would jeopardize somebody's life. And this is true for law enforcement and other first responders as well. And so I think in terms of argument, that would be our most obvious position.
So
what I'm sorry, it looks like you wanted to.
I was just going to throw out there, CIT in this county, we work very closely with the Commission on Human Rights, and they're a well-known organization that is very successful in litigation and protecting consumers' rights. I'm very proud to say that they took a look at our SOPs. They actually consult with me and my lieutenant on occasion on helping out other counties. With that said, I feel very comfortable on the processes that we have invested in this county with EMS, ourselves, and all the providers that deal with consumers. I'm very confident that we are very well protected and well known in the processes that we have.
I'll tell you, just very briefly, I've been an ER doc primarily in this area, but I've been a paramedic in 3 different states, and I can't tell you how impressed I've been with CIT. Both in the field and in the emergency department. I think y'all are a very professional organization, and every time I've had an interaction with you, you've been very focused on doing what's best for that person. So I do think we're on pretty good ground here, which is one of the reasons I wanted to have y'all come talk. So from the liability standpoint, there is a medical legal expert in emergency medicine named Dr. Greg Henry, and one of the things he always says is your best defense against civil liability is to be able to say with a complete straight face, because you mean it, that I did for that patient what I would do for my own family. So
Absolutely.
I understand that's pretty good.
Absolutely.
Now, I mentioned I wanted to make a distinction between civil liability and criminal liability, and I frequently hear this thrown around that our medics are concerned that we may be accused or charged with kidnapping. So first off, and we'll get to what actually kidnapping means, but if you don't mind, from a civil standpoint, you said anybody can sue anybody for anything.
Yeah.
From a criminal standpoint, can I charge you as a public citizen with a crime? So who gets to do that?
No. So if somebody wants to charge somebody criminally, their step is to go to a law enforcement agency. And they can make whatever complaint they want to that agency, but it's up to the law enforcement agency to investigate it and determine whether or not a crime has happened.
Okay.
And then from there, the story doesn't end there. Then they have to present that to whichever prosecutor's office would handle that case, and and see if that office will accept it, if they believe that the evidence meets a particular criminal statute, and then if so, then it actually gets filed. So there's several different processes it has to go to before it would even go to court.
And I'm assuming then that has, fortunately, I have very little experience with this, on either side of it, thank God. There's a specific standard that has to be met. I take it there are definitions.
Yes.
So if we're talking about kidnapping, what does that mean?
Well, me coming
So,
from
yeah,
coming
anybody
from
jump in
patrol.
here.
So if I receive that call from Joe Public
Uh-huh.
saying, "Hey, EMS kidnapped me," the
Mhm.
first thing I'm going to do is I'm going to go into my penal code and look and see what elements is going to fit that. What criteria do I need to meet for that offense? As soon as I look up kidnapping, I see intent to cause harm, used for ransom, using a person as a shield, to intentionally take a person's liberty, away from them, holding them, against their will, all these different things that, it doesn't. What they're telling me is obviously not going to meet that element of that offense based on what the penal code tells me, so.
Right. If I think I heard some version of the word intent about 5 times in what you just said.
Mhm.
So intent is a really,
Yes, sir.
Yeah.
and absent some situation that I feel comfortable saying hasn't happened here, no one intends to take the patient against their will for nefarious purposes.
Correct.
We're trying to do for that person what we would do for our family.
Yes, sir.
All right, so I don't think kidnapping is an issue here then. All right, so let's talk about just some terms. If you don't mind, I've heard a couple of terms about emergency detention, ED. I grew up in emergency medicine in Bell County. We talked about OEDs. I've heard POECs. What is the difference here? What does the word mean? And is there a right term?
Okay, so the correct legal term is emergency detention.
Okay.
The last legislative session, which was 84th, I believe, they started looking at the mental health code and realized that there's a lot of gaps and a lot of things that need looked at and redone and standardized. And one of the things they did is standardize the name, which is emergency detention. And they also created a specific form to use because every agency used a different variant. Now, every agency across the state has to use one form only, and call it emergency detention. So the correct term is an emergency detention.
So, good. So there are multiple forms here. We have this thing that exists only in Williamson County called a purple form, or formerly the form, the
Used to
piece of
exist.
paper formerly known as. Hopefully, it stays
Well,
away from fentanyl. And then there's this emergency detention form,
Right, correct.
and then there is a medical transport form.
Right.
So help me out. What's the difference? And
So the purple form is the medical transport form. That actually was copied from Travis County. Travis County EMS uses the medical transport form.
so we can blame
But
them.
you're right. But their copy is white.
Okay.
Ours just happened to be purple to stand out in a sea of white and
Sure.
yellow medical charts. Now that most hospitals are going paperless, we're trying to refer to it as its name, which is medical transport form. And that is not a legal document.
Okay.
All it is information to be passed on from the field to the hospital to us. So, for example, let's say Shannon is the officer on scene and sees that the person is suicidal.
Mhm.
She writes on the form, person is suicidal, puts on contact information, collateral information. There's a series of check boxes on there for further observation. It goes to you as a paramedic. You take it to the ER. TA may see it as a nurse, and it will flag them that CIT needs to be contacted at one point, but it also flags them to contact their social workers.
Okay.
As you know, without a form like that in the past, Shannon would see the person and say, this person's suicidal. After talking to you, after talking to TA talking to the shift nurse, to the charge nurse, to the other doctor.
I don't know.
Stories
He's just drunk.
You know, 3
Yeah,
days
exactly.
later, we
I
would
don't wanna deal
get
with
called, we would show up, and we would ask the doctor or the nurse, why are we here, what's going on? And more often
Because
than
they were
not,
here when I got
the
here.
answer was, I don't know, they just got passed on, we were told to call you guys.
Yep.
And by then, either the crisis has passed, or the person's not being honest with us, and we can't do a valid assessment because we don't have any information. So it's valuable as far as information.
So that form has no legal meaning,
No.
and really it's just a way of relaying information.
Correct.
Okay.
Yes, sir.
And it's a courtesy thing that actually helps the patient consumer out.
Yes, sir.
Okay. And as an ER doc, I get this constantly from nursing homes. A demented patient shows up in my ER. Hi, ma'am, what's wrong? Drool, drool. They don't say anything. I have no idea why this patient is here.
Yes, sir.
Same thing with a mental health patient. If you send them there, what am I doing? So that form actually does help me.
Okay.
What an ER doc wants more than anything is a disposition. I just need to know what I'm going to do with that patient. I don't really
Yes,
care
sir.
what it is. I just need to know, and that helps me. What I'm going to do is wait until I make sure there's no medical emergency, and then I'm going to call you.
Yes, sir.
So I'm pretty happy with that. There were a couple of terms thrown around in terms of arresting a patient versus putting them under civil detainment or detention, and I think perhaps as someone I've never been involved in law enforcement. My experience is always in medicine. I was under the impression that there was a distinction there. Can you address if there's a difference between those terms, what the difference is, or am I just confused? Because I'm confused pretty frequently.
Same here.
Well, I mean, in a criminal
I know.
standpoint,
Perfect.
there can be a difference between a detention and an arrest. I mean, we know this. When you have someone detained on the side of the road where the officer suspects them of something to the point where they actually have probable cause now that they've committed an offense, and they arrest them. So in that respect, there can be distinctions. In this respect, when the officer takes custody of the individual under the statute, it's called an emergency detention. It's not an arrest. It's not criminal, and that's something we try to make a very distinct line about. We aren't criminalizing mental health by any means. But ultimately, what it's formally called by statute is a detention, which is a form of custody.
Okay.
I think
So
And
really,
that-
it's a distinct for our purposes. It's a distinction without a difference.
Correct.
Verbiage.
And the basis is there freedom of movement?
Okay. See, I like this because
So
this is really where the
If there's
rubber
no
meets the
freedom
road.
of movement, it doesn't matter what word you choose to use, as long as there's a restriction on that movement, that person's detained, custody, under arrest. But Shannon is correct. Since we're
Okay.
dealing on the mental health side, we're going to use the word custody
Okay.
just to normalize, standardize all the verbiage, and but it comes down to freedom of movement.
So I think the thing that is important for me in the emergency department and for our paramedics on scene is, do we have the ability legally to say, I'm sorry, you cannot remain at home. You have to go where we tell you to go. I mean, legally we have that ability. We, meaning the system.
The system.
Yeah,
Mhm.
involving law
Yeah.
enforcement. Okay. Regardless of what we call it.
And-
So we can call it civil detainment, we can call it custody. Honestly, it doesn't matter. If you say the patient is a threat to themselves and needs to go to the hospital, there's no kidnapping, there's no nothing. The patient, okay.
I revert
We're all
back to the
covered.
health and safety code and the penal code, and that's
Okay.
what I'm basing my actions off of, good faith for their safety.
And it's all a system of checks and balances from the field officer to EMS to the doctor at the ER, the nurse, the social worker, us, ultimately to the psychiatrist at the inpatient mental health facility, making that final determination of whether that person needs to go there. So we've actually done a really good job of on the criminal side, it would be chain of custody. I guess on this side, you can say checks and balances to detention.
Okay. Well, let me give another scenario. Let's say we are in another jurisdiction, and obviously we are never outside of your jurisdiction because you cover the entire county. But let's say we're in a municipality where there's another primary law enforcement agency, and we're on scene with them. We feel like the patient is a threat to themselves, and they need to go to the hospital. But the local law enforcement agent officer there doesn't feel like that and is not willing to restrict their movement and say, no, you have to get into the back of the ambulance. What recourse does the medics, excuse me, pardon that horrible grammar, do the medics have at that point?
The paramedics can always call us. They can always get a hold of dispatch to have the available CIT, call them, and we will always offer guidance.
Okay.
We have 9 deputies that cover the entire county 24/7. So with training, illness, vacation, whatnot, I usually have 3 guys working an entire day, which more than often puts me at 1 deputy covering the entire county in the first few hours of the day and the last few hours at night. So they're not always readily available to go in person and assist, but they can at least pick up the phone and call your paramedics and offer some guidance.
Okay.
Because this is a very big team effort, we rely on those law enforcement agencies to help us and help you and ultimately help their resident and their consumer into access of care, because with 9 deputies, I can't cover the whole county all the time.
If I could say this real quick,
Yeah.
I mean, there's actually been an instance, I was just recalling it, where that exact scenario happened. A PD said that I don't believe this person is a serious risk to harm themselves or others. EMS staff says, yes, we believe that if this person doesn't go, that they may harm themselves or others. They actually called. I spoke to them over the phone because I was en route to another field call, and at the time I was the only one available. But I explained to them, based on what the EMS staff member was telling me, I agreed. I believe that they should be going, and so I asked to speak to the officer on scene. By speaking to the officer on scene and explaining to him, hey, this is what EMS's concerns are. This is what they were told. In that case, it was something that they confided into EMS that they didn't tell the officer. So really, it was just about communication. And then once, I think with our relationship with the police departments in our county, they take us at our word. And when we say, you know what, we really believe that they need to go, then they respect that and honor that. And so in this case, the officer told EMS staff, you know what, let me go ahead and fill out the purple form. With his
Medical
verbiage,
transport.
medical
Right.
transport form, and I told him, I said, just if you don't mind doing me that favor, let EMS go ahead and take them, and then we'll follow up with them, So the way it flowed was really good.
So I guess in our terminology, we can always call in a consult.
Yes, sir.
Instead of calling me for hey, is this person dead? You can call CIT and say, listen, I'm really concerned here. Can you help me out?
Correct.
You may not be able to show up on scene, but you can certainly offer advice, and you can talk to the officer on scene. I like it. So let's say that we're on a scene, everybody involved, except maybe the consumer there, the patient, knows they need to go to the hospital. So it's not a determination. We have determined that. Everybody's on board with it. The patient didn't have any of it. So do we have the ability to, this is a moot point because we all know this, let's say we determine we have to restrain them. Are there any legal issues involved with restraining the patient? So for example, if we say the patient needs to be restrained, let's just refocus it a little bit, lest we get off into a ketamine hole. There is, we have the patient restrained. Does the officer have to be in the back of the ambulance with us? So I'm going to ask you this as Williamson County CIT.
Okay. As Williamson County CIT, I have ordered my deputies that when someone needs to go in the back end of an ambulance restrained, that my deputies ride in the ambulance. If there is absolutely no other way to get there, they will at minimum follow the ambulance, but I require my deputies to be in the ambulance.
Perfect.
As far as our patrol deputies, our captain has issued an order that they will try at their best to ride in an ambulance and then get a ride back.
Okay.
But at the very minimum, we will follow. Yes, sir.
Okay. I understand you have weapons in your car and valuable stuff that you might not want to leave lying around. So I understand that. So let's go back to another scenario. The patient is in the back of the ambulance. Law enforcement isn't there. Say you're following and we get separated for whatever issue. And the patient who is not restrained says, that's it, I'm done, I'm getting out. If the patient, let's say we're driving down 35, 80 miles an hour, in an 80 mile an hour zone, of course, and the patient actively unbuckles, you can't stop me, I'm going to kill myself, and tries to get out. My understanding is that we have all the protection in the world if we can safely physically restrain them. Even though we may not be a law enforcement officer, we are covered, we can restrain them to the point where we can slow down and make this safe.
Yeah.
Is that your understanding?
Yes, and
Okay.
I would ask, please, please do so. Please
So
don't just stand back and let them jump out of a moving vehicle.
So that's our policy. The thing I want to stress here is if you can safely do that, If I have to make a decision as a medical director to tell you whether to put your life at risk to save this person's life, I'm going to tell you let them jump. But let's just say you can do this safely, then do it safely. Once the vehicle is stopped and they are no longer an imminent threat to themselves, our policy is I'm not asking you to put yourself at risk. We will ask you, however, to do everything you can to convince the person while calling for law enforcement help not to run out. But I'm not going to ask you to physically restrain them. All right. I guess the last thing that I wanted to cover is how are we going to get this information out to everybody so that everybody's on the same sheet of music, if you will. For us, we've sent out some letters, some forms, we have processes, and we're doing this video. Well, I'd like to just wrap up here and say, well, is there anything that we missed that you think is really important, or anything that you'd like to close with?
Well, since this is going to be viewed by law enforcement and I guess other CIT officers, I would just personally request that with regard to the NED, that it just...
Note of emergency detention.
Yes.
Yes.
That it just be written clearly and just, I know there's not a lot of information included in it, but just as much as it can be. It's really helpful on our end because ultimately it ends up on our desk if we have to commit them further. So,
More information.
and well, good handwriting.
Is there anything y'all would like to close with?
I personally am very proud of the work the entire county's done. I will tell you that recently we went to a national conference. We are right up there with the biggest counties, and we are a model for the smaller counties. So I'm very proud that Williamson County is very progressive, and it takes the willingness of everybody in the process to work together, be open-minded, and work through the issues. So I'm very happy with where we've come, and we still have a ways to go, but I think that all the players are doing their best to make it work.
Well, hopefully we'll never stop improving.
Oh, absolutely.
Awesome.
Yeah, my thing is just I think it's awesome as far as communication, you know, all the different entities, because ultimately we're all here for the same reason, which is to give the best quality service we can to our community. So I think it's great to sit down and discuss and hash out through things and come up with good finalized determinations on what needs to be done, what needs to be put in place. So
Awesome. Well, guys, thank you all very much for coming. I really appreciate this. I think it's been a fascinating discussion. I know that we didn't hit every question that you may have, and I suspect, like any of these discussions, some of the answers that we've had may have stimulated further questions. So if that's the case, please send those in, and we can, Nick has said he's going to put together a frequently asked questions. So I'd like to keep this discussion going. This is a process, and like all of our processes, it's something we continually work to improve. So I'd appreciate your feedback. Well, thanks a lot, y'all.
thank you.